The time that you should seriously consider joint replacement is when simple things don't work. Things like that Dr. Stryker has talked about, such as injections, exercises, braces. When these don't work and the joint is starting to run your life, that's when you should be thinking seriously about a replacement. You don't wait until such time as the joint has taken over your life, and it's not a question of waiting until the last minute or as long as you can. You go into it in good shape and then you get through it easily. If you wait until you're in a wheelchair, it's very hard to get back a desired level of activity. A common question that follows what kind of patient would be what age? And there was once a dictum that thou shalt be 65, but that stems from a time when the average life expectancy was in the high 60s and the implants didn't last all that long. With current materials and current techniques, a hip replacement should last 20 to 30 years. And so that the age range where people are legitimate candidates for hip replacement has been quite expanded. So a total hip replacement is effectively replacing a ball and socket joint with a ball and socket joint. They are artificial parts serving the same function. So the top of the femur or the thigh bone is basically a ball, and that ball is taken out, and instead a metal or a ceramic ball is placed in its position. To fix that, there's a shaft or a stem that goes into the femur to hold it in place. And on the cup side and the pelvis, the natural socket is called the acetabulum, and so there's a metal and plastic socket that fits into the pelvis, and so the articulation is then either metal or ceramic on plastic. There are no nerves in the metal or in the plastic, and so the pain associated with the rubbing of the bone on bone in the joint is relieved. The traditional techniques for hip replacement have all involved either detaching muscles to get into the joint or sometimes cutting the bone in order to get into the joint. In which case, on the way out, you have to repair the bone or repair the muscle. This then requires for the patient to protect their weight bearing until the muscles heal, and then you can start to enjoy the replacement. On the other hand, with the direct anterior approach, the entire surgery is done between the muscles. And so like Venetian blinds, you can put your hand into the Venetian blinds, see everything outside perfectly well. When you take your hand out, the blinds collapse, and muscles are back where they belong, no damage done, the recovery is much faster. The misconceptions that at least come to me really have to do more with when to do the surgery. And people are told, well, you're too young, or they're 58 maybe, or they're 62. No, it's a question of how much impairment the patient has from the joint and what their overall health is. So you want someone in decent health to do the surgery. Someone's very sick, it's a higher risk procedure. Other misconceptions that come to me have to do with complications that they may have seen or heard about. The patient who has a well-functioning hip replacement will disappear into the crowd, and you never know that they have a hip replacement. On the other hand, the patient who has complications will stand out and will tell people. And so this is why the choice of surgeon is important. You want someone who is experienced with modern techniques, and then your complication rate is going to be much lower. Now, any surgery has potential complications, and hip replacement surgery has a potential, for example, for dislocation. I've done more than 2,000 direct anterior approach replacements, and my dislocation rate is about 0.2%.